Hi, once again welcome back to obstetrics and gynecology videos. Today we are going to see the relationship between the fetus and the maternal pelvis. On the basis of this relationship only we are telling the lie, presentation, presenting part, attitude, denominator, position and cephalic prominence. First, let us see what is lie. Lie is the relationship between the long axis of the fetal ovoid to the long axis of the uterine ovoid. That is, in another word, we can tell it is the relationship between the long axis of the fetus to the long axis of the mother. Or otherwise, we can tell it's a relationship between the fetal spine and maternal spine. So, the common lie that we can see include longitudinal, transverse, and oblique. See, in this picture you can see the longitudinal line. See, here the maternal spine is longitudinal and the fetal spine is also longitudinal. In this, both are in the same direction, and the head is coming to the lower pole of the uterus or lower side of the uterus. So it is longitudinal line with vertex presentation. Vertex is in the lower pole of the uterus. See here also the lie is longitudinal. That is, the fetal spine is corresponding to the maternal spine in the same direction of that of maternal spine, but instead of the head, here the breech is there. So here the lie is longitudinal, but the presentation is breech presentation or buttocks is there in the lower pole of the uterus. And here you just see this is the fetal spine and it is in transverse when comparing to the maternal spine. So here the lie is transverse lie, and here the part which is coming in the lower pole of the uterus will be shoulder. So it is known as shoulder presentation. And sometimes you can see the oblique lie also. The baby may lie obliquely in this direction. Next is the presentation. It's a part of the fetus that lies over the pelvic inlet and occupies the lower pole of the uterus. That is the part of the fetus which is coming in the lower part of the uterus or in the lower segment of the uterus, and naturally or automatically that part will be lying near to the pelvic inlet or lying above the cervix. So on the basis of this we can have, or we are having three presentations: cephalic, that is if the head is in the lower pole of the uterus; podalic or breech if the buttocks is in the lower pole of the uterus; and shoulder if the shoulder is in the lower pole of the uterus. And we know that already we have seen about the lie. In this cephalic and podalic, the lie will be longitudinal. In the shoulder we have seen the lie is transverse. See, here this is the pelvis, and here the fetal head is coming to the towards the inlet of the pelvis or towards the lower pole of the uterus. So this is vertex presentation. Here the buttocks is coming in the lower pole of the uterus. So this is breech presentation. Here the shoulder is coming to the lower pole or it is entering into the inlet of the pelvis. So this is shoulder presentation. Next, presenting part. This is the most dependent part of the fetus which is felt on the vaginal examination. That is, which will be felt by the examiner first in the vaginal examination. In the cephalic presentation, it depends on the degree of flexion of the head. If the head is fully flexed, occiput will be there. If that is vertex will be there. If it is not fully flexed, brow will be there. If it is fully extended, face will be there. And in deflexed head also, sometimes back may be there. And in breech presentation, flexed breech will be there. That is, the fetal legs will be fully flexed. That is, the thigh will be flexed towards the abdomen and legs will be flexed towards the thighs. That is, knees also will be flexed and hip joint also will be fully flexed. That is known as flexed breech. And extended breech means in that case the knees will be extended but the hips will be flexed towards the abdomen. That is extended breech. And another one is footling breech. In that case both hips and knees will be fully extended. See, in the head presentation already I have told you, in the cephalic presentation here the head is there, and face presentation, here the face is there, head is not fully flexed, so face is coming into the lower pole of the uterus, and here vertex occiput is there, and here fetal brow is there. and this is frank bridge, that is the hips are fully flexed but the knees are extended. So the knees are extended towards the head. This is frank bridge, and this is complete bridge, that is both hips and knees are flexed. And this is footling bridge, that is hips are extended and knees are also extended. You can see the foot which is extending or which is coming out of the pelvis. Next is attitude. Attitude is the relationship of the fetal parts to each other. The main attitudes are flexion and extension. The universal attitude is flexion, that is the fetal head will be flexed over the chest and the arms and legs will be flexed in front of the body and back will be curved forward. This is the universal attitude, and this is the normal attitude. This will be the position of the baby. The head will be flexed towards the chest. The hands and knees both are flexed towards, fully flexed, and it is towards the front portion of the body, and the back is also curved forward. So the baby will be almost in a C-shaped manner. This is the universal attitude and it is fully flexed. And next is the denominator. Denominator is the arbitrarily chosen point on the presenting part of the fetus which is used to describe the position. That is, on each and every position presentation, one particular point will be coming in contact with the landmarks of the pelvis. That part is the denominator. Now we can see the denominator in different positions and presentations. In the cephalic presentation, if vertex is occipito-anterior, that is if the vertex is pointing towards the this portion, you just leave now because I will be explaining it later in the future slide. With the help of picture I will be explaining. That is, if the head is fully flexed, occiput will be the denominator. You just remember it. And if it is slightly reflexed also, occiput will be the denominator, because here now we are discussing about the denominator. And if it is extended, brow will be the denominator. If it is fully extended, complete extension is there, means chin or mentum will be the denominator. That is, in the brow presentation, denominator is brow. In the cephalic presentation or in the vertex presentation, occiput is the denominator. And in the case of face presentation, chin or mentum is the denominator. And in the case of breech presentation or podalic presentation, sacrum is the denominator. And in shoulder presentation, acromion process of the shoulder is the denominator. Remember these denominators, please. That is, in vertex presentation, occiput, in brow presentation, brow, and in face presentation, chin or mentum, that is the middle point of the chin. Already we have seen all these parts in the fetal skull. And in breech presentation, it is sacrum, and in shoulder presentation, it is acromion process of the shoulder. Next, we can see about the lie and frequency of lie. In 99.5% of the cases, the lie will be longitudinal, and in 0.5% of the cases, you can see transverse or oblique lie. And in the longitudinal lie, in 96% of the cases, vertex will be the presenting part, or the head will be coming into the lower part of the uterus. And in 0.5% of the cases, face will be there, and in 0.5% of the cases, brow may come. And in the longitudinal lie, in 3% of the cases, breech will come. And in transverse lie, 0.5%, already I have seen, shoulder will come as a presenting part. So in 96% of the cases, vertex will be the presenting part. Remember that. Next is the position. It's a relationship of the denominator to 4 quadrants of the maternal pelvis. The denominator, already I have told you, the common denominators are occiput, sacrum, brow, mentum, and acromion process. So this position is the relationship of this denominator to 4 quadrants of the pelvis. If you are dividing pelvis into 4, see, if you are just dividing pelvis into 4 quadrants, where this occiput, where this denominator is coming. If it is coming over here, one position will be there. If it is coming here, one position will be there. Like that, on the basis of that, we are telling the position of the baby. Now let us see the different positions in the vertex presentation. In the vertex presentation, that is cephalic presentation, left occipito anterior, that is left occipito anterior. See here it is marked. Here we know that in the pelvis this point is the if you know the anatomy and physiology, and if you know the female pelvis thoroughly, we know that this is iliopectineal eminence. This portion is iliopectineal eminence. Here this is left iliopectineal eminence, this is right iliopectineal eminence. Okay. And if the occiput is pointing towards the left iliopectineal eminence, the position is left occipito anterior. And if the occiput is pointing towards the right iliopectineal eminence, the position is right occipito anterior. Right occipito anterior. If the occiput is pointing towards the symphysis pubis, this is the symphysis pubis, and if the occiput is here, the position is occipito anterior. That is direct occipito anterior, or sometimes we are telling it as DOA, or sometimes we are telling it as OA, occipito anterior. Here it is LOA, this is ROA, that is right occipito anterior and left occipito anterior. If the occiput is pointing towards the right iliopectineal line, this is the iliopectineal line, and if the occiput is here, the position is right occipito transverse. And if the occiput is pointing towards the left iliopectineal line, the position is left occipito transverse. Same way, if the occiput is pointing towards the back, that is if the occiput is pointing towards the left sacroiliac joint, we know that this is the sacroiliac joint. If the occiput is pointing towards the left sacroiliac joint, the position is left occipito posterior, or LOP. And if the occiput is pointing towards the right sacroiliac joint, see the marked portion over here, it is pointing towards the right sacroiliac joint, the position is right occipito posterior, or ROP. And if the occiput is pointing directly towards the sacrum, that is the position is occipito posterior or direct occipito posterior. So the common positions in the vertex presentation include LOA, ROA, LOT, ROT, LOP, ROP, DOA and DOP. And in that, in majority of the cases, the position will be either ROA or LOA, and that is the normal position. See, in this picture, once again, you can see about the positions. In the case of LOA, already I told you that the occiput is pointing towards the left iliopectineal eminence, and the sagittal suture is in the right oblique diameter of the pelvis. In transverse, you just see the sagittal suture is in the transverse diameter of the pelvis. And in LOP, the occiput is pointing towards the left sacroiliac joint. See, the sagittal suture is in the oblique diameter, in the left oblique diameter of the pelvis. In LMA, that is left mento anterior, that is face presentation. Here, the mentum is pointing towards the left iliopectineal eminence, and here the mentum is pointing towards the left iliopectineal line. Here the mentum is pointing towards the left sacroiliac joint. So here, in the case of mentum also, we can have the same positions, same as like occipito anterior, occipito posterior. Already I have told you in the previous slide. In the same way, if mentum is coming, instead of left occipito anterior, we will be telling left mento anterior, and left mento, right mento anterior, then left mento transverse, right mento transverse, left mento posterior, right mento posterior. The same way in breech presentation also, if the sacrum, I have told you the sacrum is the denominator. Here the sacrum is pointing towards the left iliopectineal eminence. So the position is left sacroanterior. If the sacrum is pointing towards the right iliopectineal eminence, the position will be right sacroanterior. If the sacrum is pointing towards the left iliopectineal line, the position is left sacrotransverse. Left sacrotransverse. If the sacrum is pointing towards the right iliopectineal line, the position is right sacrotransverse. If the sacrum is pointing towards, see here, the back of the baby is towards the back of the spine, or towards the back side of the, or towards the sacrum of the pelvis. So if the sacrum is pointing towards the left sacroiliac joint, the position is left sacroposterior, and if the sacrum is pointing towards the right sacroiliac joint, right side, baby will just turn slightly towards the right side. This position will be right sacroposterior. See here, occipito anterior, already I told you that this is the anterior portion of the pelvis, and this is the occiput of the baby, and this is the anterior frontal. So the occiput is pointing towards the symphysis pubis, and the position is occipito anterior. And this is left occipito posterior, that is the occiput is pointing towards the left sacroiliac joint, that is towards the back of the mother, towards the back side of the mother, the occiput will be there. So this is almost left sacroiliac joint. So you can tell that this marker, this screw is almost corresponds to the left iliopectineal eminence. This is to the right iliopectineal eminence. This is almost towards the right sacroiliac joint. This is towards the left sacroiliac joint. So here the occiput is pointing towards the left sacroiliac joint, and the position is left occipito posterior. Next is left occipito anterior. See the occiput, this is anterior frontal and the back side, this is the occiput. Occiput is pointing towards the left iliopectineal eminence. So this is left occipito anterior. And next is left occipito transverse. The occiput is pointing towards the iliopectineal line. It is in the sagittal suture. You just see it is in the transverse diameter of the pelvis. That is left occipito transverse. And this picture shows the occipito posterior, that is occiput is pointing towards the sacrum. See, the occiput is pointing towards the sacrum, and the sagittal suture is in the anterior posterior diameter of the pelvis, AP diameter of the pelvis. This is occipito posterior. See, the longitudinal lie is the common lie. The fetus being ovate, it accommodates itself easily along the long axis of the uterus, because the uterus is also almost ovate, the fetus is also almost ovate. So most commonly the lie will be longitudinal, and the cephalic presentation is most common. The reason is that the head is heavier when compared with the other portions, and it is compact. So naturally, due to gravitation, the heavy portion will come to the lower pole or to the lower side. So, and the bulkier breech will go to the upper side or towards the fundus of the uterus, because more space is there in the fundal region, and the breech is having more size when comparing with the head. Head is compactable and it's having more weight. So naturally it will come to the lower pole of the uterus, because the lower pole of the uterus is narrow when comparing with the upper pole. So smallest portion will be getting accommodated in the smaller part easily. So the head is small, it will get accommodated in the lower part, and more than that, due to gravity, the heavier head will be coming to the lower pole of the uterus. Next is molding. Already we have seen about the molding in the fetal skull, but once again I will tell you, the cranial bones are connected by the membranes. That is, the ossification of the cranial bones may not be completed at the time of labor. So this allows the shifting and sliding of these bones each other, and it will allow the baby to pass through the birth canal. So in case if the pelvis is not having sufficient space also, these bones will get shifted, or it will get overlapped one another, and it will reduce the diameter of the fetus skull, and it will allow the passage of the baby through the birth canal. So that is the main purpose of this molding. So the frontal and occipital bones may pass under the parietal bone. The posterior parietal is getting subjected to the molding, because the sacrum is always the denominator. So when pressure is getting applied from the backbone, the posterior parietal bone is having more chance for the molding, and it will just pass under the anterior parietal. And this compression of the fetal head, already I told you that it will help you to compensate, or it will help you to adjust through the diameters of the birth canal. For example, if the occipito anterior head is compressed in the presenting suboccipito, it will be presenting with the suboccipitobregmatic. So this will get elongated in the verticomental diameter. See, if you want to understand it, you please thorough with the diameters of the fetal skull. If in the case of occipito-anterior position, the engaging diameter is suboccipitobregmatic, and when it is getting compressed, the endovertical diameter will get elongated. So the shape of the baby's head also will be changing. So it will get elongated in the endovertical diameter. And this molding we can assess if you are palpating on the bones of the fetal skull. Even before the delivery also we can palpate it, and by assessing the molding and site of the molding, we can assess even the position of the baby also. Usually this molding will disappear if it is normal and within limit, if it will disappear few hours after the birth. And this molding actually it is occurring gradually and slowly. It is not a rapid process. So it prevents the brain from getting compressed when it is passing through the pelvis. And the grading of the molding, grade 1 means just obliteration of the suture lines will be there, that is it will just meet together very closely, that is grade 1 molding. And grade 2 molding means it will be represented by plus 2 plus, see 2 plus. Grade 1 means only 1 plus will be there, grade 2 means 2 plus will be there, and it is overlapped, it is not in close proximity, it is just overlapped one another, but it is reducible after the delivery. It will disappear within few hours after the delivery. And grade 3 it is represented by 3 plus, and it is also overlapped, and it is not reducible, or it is not getting corrected automatically, and it is pathological. The clinical importance of molding, already I have told you, it allows the passage of the baby through the pelvis easier, because in case if the diameter of the fetal skull is more when comparing with the diameter of the pelvis, this fetal skull will get overlapped each other, so the diameter of the fetal skull will be decreasing, it will get decreased, and it allows the passage of the baby through the pelvis easier. That is one advantage. And another one, severe molding can lead to intracranial hemorrhage. That is, when the baby is passing through the pelvis, if it is getting compressed all of a sudden, intracranial hemorrhage will occur. But for avoiding that, here, molding, already told you that it is a slow and gradual process. Slowly and slowly it will get overlapped. So it will not produce the intracranial hemorrhage, and it prevents that. And if you are palpating the fetal skull, you can identify where the molding has happened, and on the basis of that molding you can identify the position of the head also. So that's all about the relationship of fetus to the maternal pelvis or to the maternal body. So thank you for watching this video. See you soon with a new video. Bye.